Okay, so thanks for joining today. This is Ed Crow. A lot of new names on here today. Today we're going to talk about Medicare single payer proposals, Medicare for All being one of them, so we'll talk about the details of that. For those not familiar, Crow & Associates is a NMO. For Medicare, we're licensed in all 50 states. We work with agencies and agents selling Medicare. We do all lines of business, but Medicare is our specialty, certainly. And we have a lead program, and as I mentioned earlier, we're, I think, the only upline I know of that offers Connect for Medicare, Connecture, and Sunfire online enrollment platforms at no cost. We offer both options to agents. So if you're interested in that, we're doing a webinar on it tomorrow. But for today, we're going to talk about Medicare single payer proposals, and we're going to go over the political climate that's kind of generating this, variations on the proposals, and then we'll talk about the four of the main kind of more serious, four of the main proposals being taken seriously that are out there. So the public option, one of the most popular versions of that being Medicare X. State public options, which have already had some approvals. We'll talk about the Medicare buy-in, Medicare eligibility age change, and then ultimately, or finally, I should say, Medicare for All. So we'll hit all of them. One thing I want to talk about before we get into this is when we talk about these categories and these different proposals, there are a lot of versions of all of them. So I'm going to speak a bit generically and kind of summarize on some of them because there are, like I said, a lot of versions that have very different details in them when we're talking about this. So who knows what one or ones ultimately will, kind of be brought to the front as a legitimate proposal. But for today, we're going to talk about just in general what they look like and kind of some of the details behind them. First thing to talk about is the political climate that is driving this. I think that's fairly obvious in some cases, but in general, do some people like the idea of government-run healthcare? I think it's one of those things where maybe if you look at it from afar, it might seem like a great concept. In some ways, I guess it is. In other ways, it certainly isn't. We'll talk about that a little. But again, I don't think a lot of them know what it really means and what would come with that. I think others, there's frustration with just rate increases and the amount of uninsured people. In general, when we talk about this, the under 65 and over 65 gets blended together a lot, especially politically and in the media. But I think a lot of this dissatisfaction really stems from the under 65 market. When you're looking at the huge rate increases on group health business, how much people pay for individual health plans, just the sheer number of uninsured people. But again, a lot of that falls on the under 65 side. But when we're talking about the political climate and when we're talking about in the media, they really don't differentiate between the two. But I definitely think that's what's driving a lot of the dissatisfaction. Next thing to say is the odds of any of this passing. Certainly not impossible for any of these proposals to pass, with the exception of maybe one. But it would be difficult for any of these things to happen. Very difficult, but not impossible, certainly. There's ways that they could happen, or versions of them could happen. But right now you have a really narrow margin of control in the Senate, which would make it difficult, especially given that some conservative Democrats are against most of these ideas anyway. Like I said, it would make it very difficult, but nothing's impossible, as we'll talk about. Oh, one quick thing. If you have questions, I will answer them at the end. Please send them into the webinar, and I'll be happy to answer those for you. So another thing that drives the odds of this being against these things happening, not that they won't, but the odds are certainly against it. Physicians and hospitals are strongly against the proposals. And the main reason being because it will greatly reduce any of these proposals will greatly reduce the amount of payments, the amount of payment they receive would lower that payment amount. So I think you'll see, providers, will use that term, are in most cases strongly against this and will lobby hard against it. There's concerns, even outside of the provider community, of some of these proposals driving doctors and really especially rural hospitals out of business. And in some cases, I think that's legitimate that rural hospitals under some of these proposals certainly wouldn't be able to continue operating and wouldn't survive. The other thing is there'll likely be an increase in the Republican House representation at the midterm election. That's not showing any favoritism towards anything. It's just a historical fact. Whatever party has the president in office, traditionally, and in fact, if you look back, almost always, the House will then increase for the other party. So that's just logically what happens in that case. So that's likely to happen as well, which would make it more difficult. Anyway, so we'll talk about the four proposals. And as I mentioned, there's just a lot of variations of each, which because of that, it makes it difficult to separate them and understand them all. But I tried to organize this in a way that gives you a general idea. And finally, a lot of the variations, most of them, in fact, don't address certain areas, one big one being such as agent involvement. Sometimes it mentions agent involvement. Other times it just makes no mention of it whatsoever. So one would tend to think when agents aren't mentioned at all in a bill or proposal that means they probably won't be part of the equation, but that's an assumption. So we'll start with the Medicare public option. The most popular version of that, and there's a lot of them, is Medicare Xchoice for the public option. There's many variations of this at the state and federal level. So what we do know is with the public option, if that came into being, it would likely be run by CMS, but most likely be run by CMS with a major carrier, one of the big carriers handling claims, payments, and adjudication. Really, most likely no other way that would happen. So CMS would be at the controls, claims would be adjudicated and paid and organized by a carrier, kind of a winner-takes-all kind of thing on the carrier side. A public option also would be most likely offered through the exchange. So it would look fairly similar to what we see now on the exchange. They'd probably keep that same platform for a public option. So Xchoice Act is the most popular proposal. They would start that with a public option for individuals and small groups. It most likely would be tax credit eligible, and it would look like the exchange plans do now. You'd have silver, gold. You might have platinum or bronze options as well, but certainly would have silver and gold in all the proposals that are out there. So the Xchoice is just one of the versions of this out there, but that's the one that seems to be most widely accepted right now. Providers would be paid based on Medicare rates, and it may allow for higher payments for rural providers, because as we talked about with all parties, that's a concern. If you're going to pay providers based on Medicare rates, of course, as we'll talk about more, that would greatly reduce in some cases how much they make. But in rural areas, the providers simply just wouldn't be able to survive on nothing but Medicare rates. The Xchoice proposal would fix the employer glitch. So for those of you who aren't familiar, maybe you don't write exchange business, the employer glitch is if somebody's on the exchange getting a subsidy, but their employer or their spouse's employer offers them a group health plan that's considered a, as good as plan, then you aren't able to get a subsidy. So maybe you're on the exchange, you're getting a subsidy, your spouse's employer offers a plan, but they're not contributing anything towards the premium. As it stands right now, you're not eligible for a subsidy, and that will get clawed back from you down the road. And that's commonly called the employer glitch, and this proposal removes that. The network for this option would be substantial. The reason it'd be a substantial network is providers wouldn't be eligible for reimbursement on Medicare business, on Medicare claims, if they didn't participate. So in this proposal, providers would need to be part of it if they wanted to still get paid on Medicare. So it more or less would force the majority of them to participate in the network of the plan. So it would have a good network, whether you like the way that's being done or not. That's a different story, but it seems like it probably would be a pretty effective method. in that way. Now, there's federal public options, but there's also state level. There's multiple proposals, I think, in 23 states right now for a state level public option. Those who may have noticed, or maybe didn't, but the state of Washington already passed theirs. What does it look like? I'm sure that information's out there. Quite frankly, I was going to say that I don't want to get into that today, but I really don't know yet what it looks like, but I know it was passed, and that is out there. The state of Washington's proposal is paying providers at 160% of the Medicare rate, so they decided not to go with the straight Medicare rate. It's at 160. And interestingly, what I did notice about it is they did make some rural counties exempt, and most likely due to the fear of too many providers dropping out in those rural counties. So they approved it for the state of Washington. That's probably a precursor for other states, I would think, at 160%, but they exempted certain counties, which is interesting. Anyway, that's the public option. That's what it would look like. It would look a lot like the exchange, quite frankly. You have the Medicare buy-in proposal then. So we've all heard about that. I think the common misconception is people think the Medicare buy-in would be Medicare for all. It's not. It's not. It's different than Medicare for all. We're going to talk about Medicare for all in a little bit, but the buy-in would certainly be different than that. It would look the most like the current Medicare program, however, on the buy-in. The proposals have included age ranges from 50 to 64. What's really unclear with that is how rates would be determined. That really hasn't been specified in anything that I've seen, how the rates would be determined with that. Probably community rated in some regard, but how they would actually pick those rates, who knows. This also would likely be offered through the exchange if they go with a Medicare buy-in option. Some proposals for this include Medicare Advantage and or Medicare supplements. Other proposals are for original Medicare only. So you buy in. With some of those buy-ins, you can enroll in an Advantage plan, or the buy-in option looks like an Advantage plan or supplement. Others are just original Medicare based. These proposals make no mention of agent involvement in them. And for sure, what we can say is on the proposals that are Medicare only, that wouldn't include agents. Not sure at this point on all of these. It really doesn't mention if an opt-out would be available for employer plans, meaning if somebody has an employer plan, are they able to opt out or not? We're not really sure about that part from everything I've watched and read. But certainly with the Medicare buy-in, a concern is lower payments would most likely lead to a number of providers dropping out. And I think to the biggest extent, it would be with rural hospitals and with primary practices. Would be very hard for them to operate on simply a Medicare reimbursement for everybody. So rural hospitals and primary, family doctors and practices would probably be the ones that would be most affected by that. Another proposal is the change to Medicare eligibility. So you've probably heard a lot about that. That's just the idea of lowering the Medicare age, so lowering the age at which you can get Medicare. The two numbers thrown around a lot are 60 or 62. It most likely would be 62 because that would match up with when you're eligible for Social Security payments. So 62 would probably be the number. It would likely lead to changes in the Medicare Part B enrollment rules. Those of you who are in the Medicare business, which I believe a lot of you are here, they would definitely have to tweak the rules for when you can and can't enroll in Part B. Probably would be changes with the penalty and how that works. A lot of factors there. Also would probably lead to changes in Medicare supplement underwriting. There's been talk that would go to guaranteed issue in all states. Obviously, right now, there's only 4 states in Medicare supplement that is guaranteed issue at all times. That's New York, Connecticut, Massachusetts, and Maine. They're the only 4 all-time guaranteed issue states. But if they lowered the Medicare age, there is a chance that they would maybe make it mandatory that it's a guaranteed issue in all states for Med Supp, which from a broker standpoint isn't necessarily a positive. Yes, the idea of being able to enroll anybody in a Medicare supplement is an appealing one, However, what we found in guaranteed issue states is in some areas, for example, upstate New York, the carriers now just simply aren't paying commission on med sups because they're just getting enrollments that they don't necessarily want. So they've stopped paying commission. So would that trend, extend to other states? Who knows at this point? Employees would be able to opt out of an employer plan if they are, let's say they move it down to age 60. And you're 60, you could obviously opt out of your employer plan then because you'd technically be Medicare eligible. This proposal is one that could happen, but the problem is there would be a requirement for a lot of extra funding because Medicare right now is set to be insolvent by 2024. So there'd be a lot of money needed to make this a possibility. It could possibly be passed using the budget reconciliation because then they only need a 50-50 vote for that. So that's what makes this one more likely than the others and I guess from what I've watched and read, that it would budget reconciliation would be a possibility for this to get it passed. Okay, so those are the three proposals that you see out there. The last one we'll talk about is Medicare for All. Medicare for All would completely replace all current programs. It would replace everything out there, including Medicare and Medicaid. It's called Medicare for All, but it really would look nothing like Medicare. So I personally, when I hear Medicare for All, I figured they meant just we'll put everybody on Medicare. But that isn't the case. It would look nothing like Medicare. They just call it Medicare for All because people are familiar with the term. So really, it would look like universal health care in another country, similar maybe to United Kingdom or Canada. The proposals for Medicare for All here, or Insurance for All, we should call it, they have some similarities to the UK and Canada, but they have some things that aren't similar. So, for example, in the proposals here, there would be no private insurance or supplement coverage allowed. In Canada, for example, you can buy supplements in private insurance. Under these proposals, you would not be able to, and as a result, we can say for sure there'd be no agent involvement under a Medicare for All scenario. The other interesting thing about this is it would use global pricing. Some of you might know what that is, or maybe a lot of you. Global pricing is an old method that's was used a long time ago for reimbursements for providers, but they've definitely put that in the proposals. And more or less the way that model works is we use a hospital for an example, and I'm simplifying this a great deal. But really what that means is they pay that hospital an annual sum of money, and they say, here's an annual sum of money based on the amount of people you usually see and the health conditions you usually treat. And here it is, and you budget it. So here's your money for the year, make it work. And as you could probably imagine, the structure of that is what leads to what people talk about long wait times for non-life-threatening surgeries, or sometimes life-threatening surgeries, is simply because when you give a hospital a lump sum of money, it's then on them to try to budget that money. And that means, somebody who needs something like maybe a hip replacement, well, potentially they could wait a long time for that because that's something that would get pushed off. So when you hear people talking about, access to care and long wait times, it's usually applicable to a global pricing model. The Medicare for All proposals that are out there, they cover a really comprehensive list of health services. So more or less, they cover everything, really. And that's why they're saying there'd be no option to buy a supplement or additional coverage, because this would be very comprehensive. It would cover most services. There'd be no need for that. But there's no budget in these proposals. So, determining how much that actually would cost is a different matter. And in these proposals, there's not an answer to how a budget would be created to cover all those services. And again, with this model, major concern about rural hospitals needing to close, and ultimately, the Medicare for All is the least likely of all of these to happen. There's a very slim chance that a Medicare for All situation would occur. However, if one of these other strategies are tried, one of the three I mentioned previously, and if one of those are tried and fail, and if one of those is created and fails and causes the private sector to, so to speak, fail, then this is something that could, down the road be possible. Certain states are pushing really hard for a Medicare for All. State of Washington, for example, they're really pushing for it, but one of the reasons they're pushing for it so hard is because they'd like to offer it on the state level, but they can't because of the substantial budget requirements needed. So they would need federal money in order to do that in their state. So as a result, you see them pushing for a federal program to occur so they could afford to offer a Medicare for All type program in their state. A lot of information. Like I said, I definitely took some liberties here and summarized a lot of this and simplified a lot of it, just because if you sit down and really dig into all the proposals, and it gets quite confusing with all the variations of everything. But overall, lowering the Medicare age has the best chance of passing. The Medicare buy-in option is not likely to pass, but it's certainly a popular topic. That's the one you hear a lot about lately. The public option could potentially be passed using the budget reconciliation, as we mentioned before. That's one way it could go through on the public option. And then Medicare for All really has the lowest to very, very little chance of being passed initially. As I said, you'd have to have a failure on one of the other options or in the public sector for a Medicare for All situation to get enough steam where it could potentially be put in place. Biggest pushback on this will be from a number of groups, but certainly from providers. I mean, they are the ones they're going to push back the most. I lowballed this number, but for them it represents a payment reduction of at least 50% in most cases. In some cases, much more than that. 50% is a low number, but you're going to see really big pushback from providers, hospital systems, physicians on this. Certainly, to a certain extent, we'll probably see pushback from agents, insurance companies to a certain extent as well, if they think that it's something where it's going to be something will be pushed through that won't include us agents, won't include insurance carriers. That's it. I tried to keep it fairly short. Let's see. I think I did go over a little bit. It's a lot of information, but I appreciate you joining. I'm going to look and see if we have any questions here. And again, for those that came on late, I did record this webinar, so if you registered for this webinar, you'll get a recording. So if you missed the beginning, don't worry, you can listen to my grating and annoying voice later on. Let's see if we have any questions. Okay, we do. Somebody said if I'm talking, they don't hear me. Well, I guess it'd be kind of silly for me to answer you right now because you're probably not hearing this, but hopefully we can send you the recording and you'll be able to hear me. Somebody else gave me some information. It's not necessarily a question, but I appreciate that. I'll take a look at that when I get a chance. Would Medicare Supplement or Medicare Advantage products no longer be available? Yeah, and a number of those proposals of Medicare for All, for example, there wouldn't be supplements or Advantage plans in some of these options. Now, some of them certainly there would be, and again, it's not known for sure, but the most likely one that wouldn't include Advantage or Supplement would be a Medicare for All. Let's see, next question. How long would it take any of these options to take place? Well, like I said, a Medicare for All, you're looking at a much longer time frame because you'd need to see failures from one of the other options. But certainly the lowering of the Medicare age, that's something that could take place this term. So we're not talking something that's really far out there. Next question was what options would include agents? I think there'd be a chance for agents to be included in any of them except for the Medicare for All. So realistically, how many more years will agents be involved in selling health insurance? I don't know the answer to that question. It's a really good one. It could be I don't think this is something where agents are going to be removed from the process anytime soon. Like I said, the likelihood of any of these options passing is fairly slim. And the ones that could pass, potentially, agents would most likely still be involved in that equation. So again, I don't think this is a situation where agents are going to be out of the mix anytime soon. So if I came off that way, I didn't intend to, because like I said, the likelihood of any of these are slim, and the ones that could potentially pass, agents would most likely be involved in that. Will the new public option have significant member cost share? These are really good questions, but I just don't know the answers to them. They haven't really given a lot of detail on how they would structure the public option and what it would necessarily look like. It would have tax subsidies, so it'd probably look similar to what we have on the exchange. So it would be a situation where it would definitely be based on income, I would think. So if incomes are in a certain threshold, obviously there's going to be subsidies on premium. So for those who are making below the income, I would think the price point would look pretty attractive. For those who are making above the income thresholds, then not so much. Should agents who are health and Medicare agents, should we transition to another line of business? No, I don't think so. I don't think you need to make those kind of plans at this point. There are a lot of companies investing that are a lot smarter than me, certainly. They're investing a lot of time, energy, and resources into Medicare. I think Medicare is something that's here to stay for a while. So no, I don't think you need to look for a career change at this point. Last question makes me laugh. I won't repeat it, however, so I will leave that one off. I'll answer that question. Yeah, I guess we could. Maybe I'll spearhead that initiative, but just won't participate in it. Okay, let's see. Let's talk about the threat to rural hospitals. Do you have a ballpark percentage for how many hospitals are considered rural? I don't. The talk about rural hospitals, and I think you see that with the state of Washington when they've already had an approval and they've excluded rural counties. I'm not sure anybody really knows what that truly looks like, but I do know that your rural providers and hospitals would struggle with lower reimbursements. But a really good question as well. It looks like that's all we have. Again, they were really good questions. I don't have answers for a lot of them, to be quite frank. I'm not sure there are answers for a lot of those questions. All good questions, however. But again, just to summarize, a lot of these options aren't likely to be approved. I don't think I'm an agent as well. I don't think as agents we should sound the alarm. I don't think our business is going anywhere for a while, to be, is my best guess. But if a Medicare for All situation occurred, which again, some things would have to happen for that to occur, that's when potentially we would have some issues. But something like the lowering of the Medicare age, for those of us in the Medicare field, that would probably substantially help us. There'd be more people to enroll. So I don't think there's any reason to panic here. A lot of good questions. Appreciate you joining us today. Again, I did record this. I will send out the recording to everybody. We do have a webinar tomorrow going over the difference between Connecture and Sunfire. So if you're interested in that, please join us tomorrow. And other than that, I hope everybody has a great day, and thanks for joining.